All this scientific data sharing is very interesting. Though I'm wondering, did anyone discuss real-world procedural considerations?
Absolutely. One interesting factor with many PFA catheters is the need for a large bore sheath. Dr. Koruth and Professor Tilz both highlighted some key risk mitigation strategies.
Hello everybody, my name is Roland Tilz. I'm Professor of Interventional Electrophysiology at the University Hospital in Lübeck and Director of the Department of Rhythmology. It's a great pleasure to speak about pre, intra and post-case considerations with PFA. These are my disclosures. So I start with pre-procedural considerations, continue with procedural considerations and finish with post-procedural considerations. So what are my pre-procedural considerations? First of all, everything starts with the patient selection. Makes a big difference whether you perform a first-time ablation or a redo ablation, because a patient with a first-time ablation, usually it's a PVI-only approach, whereas in repeat ablations, you often require PVI plus additional ablation strategies. In addition, in the first two ablations, you may or may not use a mapping of the left atrium, and the procedure is typically not as complex. Whereas if you perform a repeat ablation, a mapping of the left atrium, it's mandatory. You need a high resolution mapping, and the procedure is typically more complex. What else do you have to consider? So what about imaging? Do you need TE before the procedure? Do you need a CT? I think that's rather a matter of your institutional standard than of the technology. There are centers that use CT or TE for every patient. And some centers like us, we don't perform any pre-procedural imaging. We only use TE in patients with high CHA2DS2-VASc score to exclude a thrombus, but we do not look for common ostia or adverse anatomy. We also don't perform any patient selection, so all first two ablation procedures are eligible for a PFA procedure. In repeat procedures, it's a more individual approach. I think an important question is the sedation protocol. This highly depends on the catheter that you use. If you use a catheter with a lot of muscle contraction, GA might be mandatory. If you use a catheter with hardly any muscle contractions, you may keep the patient awake. So what are the merits and the demerits? If you use a GA, you have a minimal movement of the patient and skeletal muscle recruitment. It's not a big issue. However, the procedures are typically longer and you require an anesthesiology team. If you perform the procedure in conscious sedation, the patient may move a little bit more and you have the risk of skeletal muscle recruitment. But the main advantage, it's a faster procedure that can be managed with the EP team without any additional support. We started to perform PFA procedures using the awake protocol, which means that the patient remains awake. You can continuously speak to the patient during the procedure. We have like a standardized protocol for all these procedures. And it's a very new experience for us because the patient, what they do tell is that they feel the pain. They say it's like a 7 out of 10 immediately after the application. However, they don't care about the pain. They don't fear, they're not afraid, and they're very happy and recommend it. What we learned is that we have to focus more on the patient. So it's better if not the operator speaks to the patient, but the nurse takes care of the patient, speaks to the patient, or what we just started, if the patient watches Netflix with goggles, then he is also more calm and requires less sedation. An important consideration and decision that you have to take is whether it's an inpatient procedure or an outpatient procedure. We do perform PFA procedures on an inpatient basis and on an outpatient basis. But if you do same-day discharge procedures, you need a standardized workflow. So these are for us the early morning procedures until 1 o'clock in the afternoon. We select the patients. We take only patients that are not too far from the hospital, that have a BMI of less than 40. So there is some kind of patient selection. And then you need someone, a relative, who takes care of the patient after the procedure. To typically keep the compression bandage for 4 hours, or if we use a suture device, for only 1 hour. What about our procedural considerations with PFA? First of all, it's very important that you give atropine. So for us, I think the key difference between an RF-based procedure and a PFA procedure is that when we do the transeptal puncture, we not only give heparin, but we also always administer 1 milligram of atropine in order to prevent the vagal response. We don't need RV pacing. We don't have an RV catheter in order to pace. I do know that some institutions still have an RV catheter to be prepared. We give more heparin as compared to thermal procedures, because typically the procedures are so fast that by the time we take the first ACT, we are already reached the end of the procedure. So we would typically give like around 2,000 units of heparin, more than for an RF-based procedure or cryo procedure. And then you have to take a decision whether you use TE, ICE, or a 3D mapping system. In my opinion, if you use TE or ICE to guide the procedure, that's rather a matter of taste. However, I think there is more evidence for 3D mapping systems. So do we have any data supporting the use of a 3D mapping system? Recently, there was a study published from a Swiss group that did not find any benefit if you use this 3D mapping system as compared to a fluoroscopy-based PFA procedure using a pentaspline catheter. However, if you look into the Manifest Redo study, which was published by Daniel Scheer, they did find a higher PV isolation rate in patients who underwent a 3D mapping-guided procedure. What is practice? What is common practice? Do people use 3D mapping system or not? This is highly dependent on the catheter that are used, the country that, in which the procedure is performed. If you look into the data, for instance, from the Euphoria registry, it's a European registry, only 1 out of 3 patients had a procedure that was performed using a 3D mapping strategy. Whereas if you look into data from the US, most US centers would use 3D mapping system. Is there any benefit for using a 3D mapping system in addition to wall contact assessment? Yes, there is a very clear benefit. For instance, if you see on the left side, for instance, it's a patient with a common ostia. And what you can nicely see is that you can isolate first very deep the vein on a very distal level. But if you identify the antrum of the ostium, you can pull back the catheter and add a more antral lesion in order to get a wide area circumferential ablation. In addition, with the mapping system, you can better understand and you can also treat the substrate, like in the patient on the right-hand side. He had low voltage area in the posterior wall and it was treated with posterior wall ablation, and this is the mapping post-ablation. What you also have to be aware is of PFA-specific complications, such as coronary spasm, which may occur during a PFA ablation. The underlying mechanism is not completely understood. It typically occurs if you deliver the application in close proximity to the left or right coronary artery, but it may also occur independent of an application close to a coronary artery, or you may even get a diffuse coronary spasm. That it may result in VF, and the acute treatment of choice is the administration of nitro. If you deliver energy, PFA energy, right on the coronary artery, if you perform flutter or left atrial isthmus ablation, you should give nitro in advance. There are different protocols to prevent this complication. However, at present time, we do not know the long-term consequences of this coronary narrowings because it has been described that part of this coronary narrowing persists over time. Another important complications if we treat our patients are stroke and tear and of course tamponade. And the tamponade risk is with early studies about 1%, and with increasing experience it decreased with first generation PFA tools. And the stroke rate ranges from somewhere between 0.5% to more than 1% in the early phase of these new technologies. So what can we do to prevent stroke? I think one important contributor is air embolism, and that's why optimal sheath management is of utmost importance. So what we typically would do is we aspirate large sheath with a 50 ml syringe in order to get rid of all the air. We would insert the catheter below the level of the heart, and we inject the line with the syringe during insertion of the catheter in order to get a positive and not a negative pressure. This is highly effective to prevent air embolism. And last but not least, it has to do with the quality of the valve and the sheath. If you use a high quality sheath, the risk for air embolism is much lower. Another important complication is phrenic nerve damage. And this is also a matter of concern. Overall, the risk appears to be much, much lower as compared to cryo-based ablation. However, there has been a recent publication where they described a 40% injury of the phrenic nerve, and 24% of the phrenic nerve injury persisted at discharge, and at 3 months follow-up there was still one patient with persistent phrenic nerve injury. What about inflammation? In general, inflammation appears to be much less pronounced as compared to dermal ablation. That's why we probably in the future will reduce the blanking period in patients undergoing PFA ablation. However, there appears to be a significant difference in between different catheter and catheter designs on inflammation. We compared a pentaspline catheter with a balloon in basket design, and what we found is that with the pentaspline catheter we had a significantly more inflammation, and we, despite the fact that the myocardial damage, the myoglobin and the troponin was similar. What we also found is that the use of a pentaspline catheter resulted in significantly more hemolysis and a measurable decline in the GFR, which could not be noted in patients undergoing balloon-based PFA procedures. What about the post-procedural considerations? I think the most important post-procedural complication is the vascular access management. This starts with the puncture of the groin. I think it should be mandatory these days to perform an ultrasound-guided puncture in order to avoid groin complications, bleeding, esophageal fistula formation. You may or may not use a vascular closure device, but I think what should be also standard of care, at least, is a figure-of-8 suture or other suture techniques in order to get the patient mobilized quickly with pressure bandage and figure-of-8 suture. We would typically keep the patient in the bed for 4 hours. And then we went the next step, and for our outpatient or same-day discharge patients, we treat them with a vascular closure device because we could demonstrate in the STYLE-AF study that you have a faster time to ambulation, a faster time to hemostasis, and faster time to discharge eligibility if you use a vascular closure device as compared to if you use a figure-of-8 stitch. Dear ladies and gentlemen, I would like to come to my conclusions. Pre, intra, and post-procedural considerations. So the pre-procedural considerations are predominantly concerning the imaging, the patient selection, and the sedation. I think the sedation is highly dependent on the catheter that you do use. The intra-procedural considerations are predominantly considering specific complications, such as coronary artery spasm, that you have to be aware of and have to be able to manage if you start using PFA. And you have to adopt your workflow, for instance, to administer atropine in order to prevent a vagal response. After the procedure, you have to optimize your vascular access management in order to increase patient satisfaction and reduce the most common complications, which are vascular access complications. Most of all, choose your system with full disclosure. All PFA systems differ in terms of unwanted effects. I hope you enjoyed the session, and thank you so much for your attention.
We're now going to talk about large bore venous sheath management. In the world of PFA, it's become very common that we are now routinely using large bore venous sheaths. Access for large bore venous sheaths is critical because we want to reduce the risk of complications to our patients. And it's widely agreed upon that ultrasound guidance is in fact the best way to get venous access. While getting ultrasound guidance, it is important not to puncture the back wall of the vein. It's equally important for us to understand closure techniques for access sites. Whether it's a figure-of-8 stitch or whether it is devices that are used for dedicated venous closure, you need to be really familiar with these devices so that you get immediate venous stasis and that you don't get complications. I'm going to take you through a number of complications related to large bore venous sheaths. Remember, these sheaths are oftentimes quite stiff, and you have to be wary of not causing trauma in the IVC, especially when you're going up with stiff dilators. You need to be careful when you introduce these into the left atrium, have the wire out in the PV so that you're not damaging the vein or the left atrial wall. And if you're using these venous sheaths for transeptal, you have to be particularly careful when you do this. It's very important for these large bore venous sheaths that your ACT levels are at the recommended doses. You also need to make sure that these sheaths are in continuous flush because clots can form within the sheaths quite easily if the ACT levels are low or if the flush is not adequate. The next thing that I want to talk to you about is air embolism. Air embolism can happen at 3 points: when catheters are inserted or exchanged, when the sheath is being exchanged, or during the performance of transeptal procedures. This is critical. We have gotten so used to managing sheaths and doing transeptals that some of the complications that I mentioned above are relatively uncommon. But as our sheaths get bigger, we need to be very careful about air embolism. Remember, when you have a sheath or a dilator or a wire across the transeptal axis, entraining of air during deep breaths, which results in negative intrathoracic pressure, something that you typically see under deep sedation, is something that you have to be really wary about. The lower the left atrial pressure, such as in a dehydrated patient, the more airway obstruction they have, the greater the negative intrathoracic pressure manifests, and the easier it is for air to enter the left atrium. This is just an example from the manifest registry to show you that strokes happen not just from left atrial manipulation or clot formation, but catheter exchanges and sheath management are equally important causes of strokes. And having a dedicated workflow on how you manage sheaths is important to reduce this risk. These are 2 examples of large bore deflectable sheath. You have the Agilis 13 French dual reach sheath and the Farad Drive 13 French single curve sheath. Both these sheaths are commonly used to introduce multi-electrode catheters for PFA, and I'm going to talk about 2 slides that tell you how best to use these sheaths in a safe manner. Remember, every time you insert or withdraw a catheter in one of these sheaths, you have to do it slowly. Rapid insertion or withdrawal usually entrains air, and this can then lead to an air embolism. Every time you insert or withdraw a catheter, remember, we need to aspirate 20 to 30 cc's of fluid using a large, typically 50 cc syringe. Make sure that you see blood come through the syringe so that you know that you've aspirated the entire content of the sheath. And this has to be repeated throughout the procedure to make sure there is no air ingress in the system. Position the handle angled down or horizontal before you insert any catheter within the system. The higher you keep the end of the sheath, the more likely air will enter the system. So it's almost routine that we always keep it ideally angled down or at least horizontal to the patient's leg. Remember, the other end of the sheath is in the left atrium, so excessive manipulation by the groin should be avoided. And most importantly, you need to know what the recommended drip rate for these large sheaths are. For the Agilis 13 French sheath, we are recommending to provide 2 mL per minute minimum drip rate using either a gravity IV administration bag or just a pressured pump.
There are so many things to consider with each case. It was nice to hear a bit of the key patient considerations with PFA.
I agree. It sounds like the program was really well-rounded, highlighting several key areas for the EP doc to consider.